It's a real pleasure to be here today to present to you. I have to admit I'm a little bit nervous because I've never been filmed before. So I've been told the best way to do that is to imagine the audience naked or on the toilet. So I'm just going to take a couple of minutes to do that. No, not a couple of minutes, because there's quite a few people I know and it's a bit off-putting really, because I just want to see you with your clothes on really. As Dr. Stennis said, the presentation is Epidural Management from point of insertion to removal and getting it right. Now I know Alison would have shown you a picture, and it's obligatory that we show pictures for the first slide at these kind of days, and Alison would have shown a picture of the pain nursing team. So I'll just make sure that I know what I'm doing with this. Oh yeah, there we are. So we've got the Manchester and Salford Pain Centre team there, it's a really good place to work at. We're a combined service. We manage outpatient work and we also manage inpatient work. And the epidurals that we're talking about today is really about inpatient epidurals. So we've got specialist nurses and pain consultants who look after the inpatient capacity and pain management. And also the specialist nurses in the team that Alison will have shown you this morning also deal with outpatient work, and we do outpatient clinics, spinal cord service stimulation, TENS, medication review clinics. And this team is also obviously a combination of different people. We've got physiotherapists, psychologists, receptionists, medical secretaries, and they're all equally important in the team. So that's just our team, and we're very proud of it. So the presentation outcomes, can I just have a glass of water if that's at all possible, please? The presentation outcomes, we're looking at what an epidural is, complications, setting standards, education, audit, and removal and ongoing management. Now I've got this little device, it's my son's device. I have to be really careful because it's got 3 buttons, and if I press the bottom button I get a shock. So I've got to be really careful with this, but it's my pointer. So if you see me jumping, that's what it is. So we do approximately between 400 and 500 epidurals, 450 and 500 epidurals a year. Majority of them are thoracic epidurals, and we have seen a slight increase, we feel, over the past few months because of trauma. We are a trauma centre now for the region, and we are seeing quite a lot of fractured ribs coming through. So not all fractured ribs get epidurals, but we are seeing some of the more complicated trauma patients with fractured ribs are actually having them. We do also do some lumbar epidurals, but they're not they're very few and far between. The types of surgery you can see that we do esophagectomies, total partial gastrectomies, and those types of operations require an epidural. Like I say, the lumbar epidurals, hip replacements are very rare, and we don't do very many of those. So I suppose we need to know really what an epidural is. And we can see that an epidural is a complex amalgam of clinical judgment, technical skills, materials, equipment, all the things that are mentioned there. But what I want to look at really is what's highlighted in yellow. It's the human error and shortfalls in performance, equipment dysfunction, and broader spectrum failures. So that's what I'm going to be looking at in this. So I suppose we need to look at what the risk factors are for epidurals as well. And we obviously, when considering an epidural for a patient, it's important the patient knows what the risk factors could be. It also allows clinicians the ability to treat those risk factors and complications also. For example, epidural low blood pressure due to epidurals. We do have a policy in place for low blood pressures caused by epidurals, and we have to consider that not all low blood pressure when somebody's got an epidural is caused by the epidural. But if it is epidural related, we've got a policy for that, which we use noradrenaline. So there's a clear policy there for staff and anaesthetists to use to actually support the blood pressure. So we see these complications and side effects. And like I said, sometimes they're related to epidurals, but sometimes they're not, so that has to be considered. The majority of operations that we do are major operations, so they're likely to have a catheter in place anyway. So we don't tend to get many problems with that. I've already mentioned the low blood pressure. Itching's quite a problem for our patients because obviously there's fentanyl in the majority of the time with the epidurals. We do get inadequate pain relief, and that may be due to a number of reasons. It may be that the epidural is not positioned in the right place. It might be that the rate isn't right. It may be that we've not got fentanyl in the epidural and we need fentanyl in the epidural. So we need to consider those when we're managing these epidurals. Other risk factors, obviously uncommon ones, rare and very rare. We've got slow breathing and catheter infection, and that's always a concern for us. We currently have just seen a patient that had a local epidural catheter infection, and there's quite a bit of pus coming out of that region. We need to monitor them very, very closely, because what we don't want to end up is the patient having an epidural abscess. This was a local infection, and we put steps in place to actually manage that, and we see the patients on a daily basis. And I'm going to go through a protocol later for epidural abscess and hematoma management. Rare factors, breathing difficulties, convulsions, and damage to nerves. And most of the epidurals at Salford are put under while the patient's awake, because obviously we want to try and observe for any nerve damage that there might be. Very rare risk factors, a permanent nerve damage, epidural abscesses, and epidural hematomas. And I think over the last 10 years, and correct me if I'm wrong here, we've probably had one definite epidural abscess. I would say two, maybe one, yeah, but one that I'm aware of. Obviously, these risk factors are uncommon. They're rare and very rare, but that's unless they happen to you, and then they're not. So we've got some pictures here. I don't know if you can see them very well. We've got a picture on the top left, and that's a picture of a patient that's had a dressing put on to try and secure the epidural. And it was sleek that has been put on. I don't know if anybody's used sleeking previously. It's a very, very sticky dressing, and if you try and take it off, it practically rips the skin off with you. So this patient has got, I'll use my thing. Let's see if I can use this. Yeah, there's some blisters there, and you can see that's not actually a dressing, that's the skin red. So we try and obviously prevent anaesthetist or whoever's doing the epidural from using sleek. Over here we've got an epidural hematoma that's been evacuated, and this picture is of a patient who's got an epidural abscess. It's not at our hospital, and she's having incision and drainage for the epidural abscess. Now this is something I think when you're managing epidurals you need to consider. It's compartment syndrome, which is a condition in which pressure within the unyielding osteofascial compartment causes compromise of the circulation. We know that it's an acute episode, and it's both limb and life-threatening, so it needs to be dealt with very, very quickly. And the outcome depends on the diagnosis and the time from injury to intervention. Now, over the past few years, we've actually identified two patients with compartment syndrome that got epidurals in place. So it's really important that that's taken into consideration. And this is done through really good surveillance of epidurals and monitoring of the patients. And both patients in these particular cases needed fasciotomies. So it is really important. Obviously, there's things that you can look at, and it's important to monitor for the possibility of compartment syndrome. So the above points will help detect and monitor if you do have any suspicions that compartment syndrome is present. And the first signs tend to be pain and paresthesia. But obviously you don't want to get down to where the actual limb is pulseless. You want to try and pick that up beforehand. So I'm going to move on to setting standards now. And the first thing I'm going to talk about is obviously patient information. And I think I've missed one, sorry. Oh no, it's gone. Oh, sorry. We're going to consider evidence-based policies, clinical observations, guidelines for epidural removal, epidural abscess and hematoma guidelines. The first thing I'm going to talk about is obviously patient information. And patient information is obviously extremely paramount. It gives the patient the information to help make an informed choice. and it gives the patient the risk factors and helps them to prepare themselves for the epidural. It also seeks concordance between the patient and the anaesthetist that's going to be putting the epidural in. I think that's really important to get the patient on board. But there are other things you need to consider. And this can be done in the pre-op clinic when the patient's been seen, if it's an elective procedure, or if it's an emergency, then these still need to be considered prior to an epidural being put in. Is the patient taking any blood thinning drugs, such as warfarin, because we don't want to cause a hematoma around the area? Does the patient have a blood clotting abnormality? Have they any allergies to the anaesthetic drug? So we usually leave bupivacaine. Have they got a severe arthritis or deformity? Because that's going to make the procedure more difficult. And we might need to use X-ray control in these patients to try and get in the right place, as Dr. Turner was talking earlier. These are the difficult patients. We want to get the epidural right so it actually works for them. Does the patient have any infection in their back? And obviously that would be contraindicated because you don't want to be introducing any further infection deeper seated near the epidural space or the spinal cord. And I think this is as a really important point is, does the patient want one? Because not all patients want one. And sometimes clinicians feel that it's going to be the best option for the patient, despite the patient not wanting it. So the patient shouldn't be coerced into having one. And we've seen previously, we've certainly seen at Salford, where a patient has been coerced into having an epidural and they didn't really want one. And they've made their mind up already that it's not going to work, and then we are left to deal with the consequences of it not working, and the patient feeling that it isn't working, and then we have to sort things out. So invariably it's better that the patient has a full informed choice of what they want. So if we look at clinical policies, any organisation needs to have clear, robust clinical policies. And we've certainly got one for the management of epidurals. And I think what you need to have when setting up a policy, that it's evidence-based. It needs to be a collaborative approach to actually getting a policy together. And currently, Alison and one of my colleagues, Fiona, are updating the current policy. And it has been interesting because we have collaborated with some different people, anaesthetists, advanced practitioners, and it's interesting getting the key stakeholders involved. And it's important because you get different viewpoints. But in the end, you have to take ownership of it. And the pain services have got ownership of the actual policy. So it needs to be reviewed on a regular basis. We do it every 2 years at Salford. But most importantly, it needs to be accessible. It's no point of having a policy there if nobody can read it or get hold of it, because all the information on the management of epidurals is in that policy. So it's really important that people can use it. I was talking a little bit earlier about the epidural abscesses and hematoma. You saw the picture. We have developed a policy for that, or guidelines for suspected epidural abscesses and hematoma, and it clearly states what to do in the event of you suspecting one. And it might be that you just monitor it for the time being, but it gives a clear pathway of what to do. And it needs to be a clear, concise pathway. It needs to be prescriptive so that you don't miss any points. Most clinicians have probably not seen an epidural hematoma or abscess. And vigilance and monitoring is obviously important, and this gives the clinicians some guidance on what to do. And we're always contacted if one's suspected anyway. With this lady that we had last week, we provided one of these guidelines, and it was with the patient all the time. So people had that information of what to do should things develop. Should the patient start losing power, what would you do in that case? So that's there all the time. The first indicator that the patient might have a problem in terms of hematoma abscess, particularly with an abscess, is the patient might report a new episode of back pain. So again, that should be taken seriously. If we look at clinical observations now, like Dr. Turner was saying, all our thoracic epidurals go to either a high dependency or surgical high dependency area for the first 12 hours. If they're stable after that, then they can be moved to a more general ward. It is a bit of a double-edged sword in the sense that the general wards don't get a lot of experience with epidurals because they're going to the ICU. But it's more important from a patient safety point of view that they're in the area that things can be picked up on. So our observations are done hourly for the first 12 hours, and we've got some additional observations as well, which we'll go through a little bit later. The guidelines are attached to the pumps. So if we've got any problems with complications, those guidelines are there to support us. So if it's low blood pressure, respiratory depression, or inadequate analgesia, it gives some guidance of what to do. So I've not listed everything, but that is there. We also are concerned about motor power, because what we don't want to happen is the epidural to block the motor power, because we want them to be able to move. When people have got epidurals in, we want them to move around with the epidurals, we want them to deep breathe, we want them to cough, we want them to have good analgesia. Obviously, we want to check the motor power, and this is what we use. So whether it be a thoracic epidural or a lumbar epidural, we have the Essem scale and the Bromage scale. The Essem scale tests the upper thoracic region, and the Bromage scale tests the lumbar region and lower limbs. So again, I think it's quite a good representation. It gives you pictures of what you should be checking, and it gives you indications of what to do should you have any concerns regarding motor power loss. It's also part of our electronic prescribing system, which I'll show you a little bit later. Now, I know this back. I'm not going to tell you it is. Epidural fixation, or epidurals, should be a closed system. Obviously, we want to reduce the risk of any potential infection, and dressing should only be changed if there's a clinical indication to do so. And as you can see on here, we've got an area, that's the epidural insertion site there. It's covered by a Tegaderm dressing. We've got Mefix around it, and the catheter goes over the right shoulder, and I'll show you another picture in a minute. So we should be using hypoallergenic dressings. We don't want this situation where we had early with the chap with blisters and excoriation on his back. And again, the site should be visible because you want to look for any signs of infection. Securing the epidural filter. That's the epidural filter there. Now, it's important that it's visible for a number of reasons. One being that it's a very hard piece of plastic, and I went to see a patient a few weeks ago, and the filter wasn't on his shoulder. It was actually embedded into his back. And it is a hard piece of plastic, and obviously if a patient has got some loss of sensation, they might not be able to feel it in any case. So it's important that it's observable, because what we don't want is an imprinted filter in the patient's back and the pressure sore developing. So it's also there for another reason as well. It's visible so we can observe for any disconnections. Because if there's disconnections, then there's obviously a chance of infection, and the patient won't be receiving any analgesic benefit. So we have got a policy for a witnessed disconnection or an unwitnessed disconnection. If we've got an unwitnessed disconnection, we don't know how long it's been disconnected for, the epidural has to come out. And then we try and plan from there. If it is witnessed, then what we do is actually the epidural catheter, we clean it with alka wipes, and we cut about 1 centimetre off and reconnect it, but it has to be done under an aseptic technique. So it's cleaned and it's put back, because obviously we've witnessed it and we've cleaned it. Unwitnessed, we don't know how long it's been like that for, so it comes out. So I suppose we need to think about how long we leave epidurals in for. And this is this form. We used to use a paper form. It's all gone now electronic. And I think it's a brilliant form, to be honest with you. I know Alison did a lot of work around this. It's about additional observations. And it gives us an indication of what we should be checking with epidurals. So we should be checking the pump handover, the site checked, the cough, they're able to cough and deep breathe, the Bromage and the Essem score, and any comments, and it's signed for. But it also indicates when we should be thinking about taking the epidural out as well, or considering removal of the epidural, or converting to another procedure. So day 3 we check it. Now the epidurals stay in depending on the surgery as well. We do a lot of esophagectomies, gastrectomies, and they nil by mouth for quite a number of days. So they could be in, the epidurals could be in for up to 7 days. We do collaboration with our surgical colleagues. We have patients that are on the ERAS pathways, the extended recovery, and I know we're going to get a presentation a little bit later from my colleague over here, so they should be going into that. Complications, whether there's clotting, infection, effectiveness. So those all need to be taken into account when deciding on when we take an epidural out. I've already said that maximum is 7 days, but we do see epidurals staying in for longer, up to 10 days for fractured ribs. Now, if they're going to stay in for that length of time, we automatically see them on a daily basis, and we monitor for, obviously, complications and signs of infection, and effectiveness as well, because they tend to become less effective over a period of time. So when we're thinking about taking epidurals out, we've developed another algorithm which indicates what we do in terms of this. If there's an oral route established, then we go on to the oral route. If there's not an oral route established and we want to take the epidural out, we'll go to a PCA, or we could go to subcutaneous opioid analgesia as well. In terms of coagulation, because what we don't want to do is obviously cause a patient to get a hematoma around the area, we don't automatically check the coagulation before taking it out, unless we've got any concerns. If we've got some concerns, then we might check the international ratio, the INR, and we like it to be 1.4 or below before taking it out. Now, I have to hold my hands up. There is a new test. Well, I don't think it's new, actually. I think it's probably been around a long time. It's called the TEG test, and this is thromboelastograph, and I only found out about this 2 weeks ago. And it's to test the efficiency of coagulation. I took one of our consultants to see a patient, and he suggested this. But I don't think it's done on a routine basis. I think it's just a more accurate test. Now, regarding taking the epidural catheter out and giving prophylactic coagulation, we use tinzaparin at Salford Royal. We have the tinzaparin prescribed at 6 o'clock at night time, because we tend to take the epidurals out in the morning, and there has to be a 12-hour gap between the last dose of tinzaparin being given and the epidural catheter coming out. With regards to giving the next dose of tinzaparin after the catheters come out, there has to be a 4-hour gap. So that gives you plenty of time. If you're taking it out in the morning, the next dose is due at 6 o'clock, you've got that definite 4-hour gap. If you don't have, if the epidural catheter comes out after 2 o'clock in the afternoon, then you have to put the tinzaparin back a little bit. It's just using common sense. So I'm going to quickly talk about equipment. Obviously, we use the Bodyguard pumps for both PCA and epidurals. So what do we need from our equipment? Well, we certainly need it to be easy to use, and more importantly, easy to teach. Because part of our role is about education and teaching, and I know there's some pain nurses here, and it'll be high on the agenda for you guys as well. Teaching education of these equipment is really important. But I think also support from the manufacturers is equally as important, particularly when you're setting up a new service or thinking of changing your pumps. Get your company involved and make sure that they do some teaching. And we had very good support from CME Medical in terms of doing that teaching. We certainly have pre-filled epidural solution bags, which hopefully makes it safer and more efficient when having a service like this. And I think we also need a good audit trail. We've got about 82 or 3 pumps at Salford Royal, a mixture of epidurals and PCAs and local infusion pumps. And they are hard to keep track of. So it's really important that you've got a good audit trail and we've got a form that gets filled in. Now, I left the pharmacy department because I think that having a pharmacy department that link in with your service is absolute a must. We've got a superb pharmacy department, a technician that manage the epidurals and the PCAs and all the pumps that we use. We, as a pain team, we wouldn't be able to manage it if we hadn't got them. So it's really important that we've got that service. And if you haven't got one and you can get them on board, please do it because it's paramount. Then hopefully what happens is you get a patient looking like that. He's had major abdominal surgery and he looks fantastic. Epidural's working well. But as we know, in the real world it doesn't always happen, does it? So what we need to be looking at is how do we approach patient safety. Now, there's lots of professional organisations out there that will support your clinical practice and give you guidance and advice. With regards to epidurals, we've got the Royal College of Anaesthetists, the British Pain Society, the NPSA, Safety Agency, and they've got all good information out there that can help with your service. What I wanted to just quickly show you, and you can't really see it very well in here, is the Raising the Standards, which is a Royal College of Anaesthetists development, and it's a compendium of audit recipes. And it's been developed by clinical experts in the field of anaesthesia and pain. And if you've not seen it, it's really good. If you think of doing a small audit, it's really good to be aware of and to use. Sadly, and the stark reality is that it doesn't always go right. And we do get situations where it goes badly wrong, and these should be never events, and this patient actually died. She was injected local anaesthetic into her arm instead of the spinal or the epidural space, and I'm sure you're all aware of this anyway, that we're within this environment. So the National Patient Safety Agency has been entrusted really to act on breaches in patient safety and identify actions that will hopefully help prevent this occurring again. Obviously at Salford Royal we've acted upon these recommendations. We've done labelling bags, we've only one strength of levobupivacaine and numerous other recommendations that we've put into place. So that's the patient safety people. Again, as we know currently, epidural lines can be use standard connections. And that's a crazy situation because this is what happens when we have standard connections, Luer lock connections that epidurals can be attached to. So I know companies are currently working towards getting a connection that will only fit epidural lines and not be able to attach to anything else. So we're looking forward to this safety thing being brought in as soon as possible. And I know we're a little bit behind on this, but I know that companies such as CME Medical are looking at these connections. So education, quickly go on to that. It's an ongoing commitment to both patients and staff, and we need to ensure that we continue educating our staff with regards to epidural pumps in particular. It helps monitor staff competencies, and it's all about staff being competent these days with regards to pumps. It should always be factored into any new service or acquisition of new equipment. And support from your company, again, is paramount, like I said a little bit earlier. So I'm quickly go on to clinical audit. And this presentation isn't exhaustive by any stretch. There's lots of other things that we could do, but obviously time limits you. But we are quite excited, really, about our data collection and audit process. And like I said earlier, we have electronic documentation now. And we have developed this, and you can't really see the side of it, but when an epidural is placed by the anaesthetist, we've got this audit trail or audit form that they fill in. So they're putting all the information in about how much is in the space, how many attempts they've used to try and get it in. So useful information that we can look at as a pain team, because we can look at all the anaesthetist information. The anaesthetists get their information back, but they only see their audit material. We can see everybody's, which is great. What we then do, it's an ongoing tool. We then fill our information, and you can see it better here. So we go and see the patient post-operatively. We look at what the operation is, what they've been given in terms of the epidural drug, the epidural filter, is it secured? So we check all the safety features that we want to ensure is happening in the clinical area. And it also looks at what the side effects have been, if there have been any. So we can look at that and we can get reports from this. And then what we also do is get some information from the patient of how well they've thought the epidurals work for them. So what we have done, and we only did this the other day, didn't we? We looked at some statistics because it is a new development and we are learning with it, and our IT department haven't given us any proper statistics yet, so we quickly looked at it, but hopefully in the future we'll get some reports through. So we can see at the moment some of our statistics in terms of percentage, and you can see the hypertension is quite high, requiring noradrenaline. But these are things we can look into and try and improve upon. Our fallout rate is 7.6%. Now we have got a new device called the Locket, and we're hopefully going to see that fallout rate reduce. The only problem with the Locket is you can't see the epidural insertion site as well. But I suppose we just have to kind of balance it out. And like I say, we ask the patient how well it's been for them. And we ask them on a scale of whether it's been excellent, good, adequate or poor, their experience of having the epidural. And as you can see, we're quite pleased that it's 84% of patients have said that the epidurals have been excellent or good. We're not complacent on that, obviously. We wanted to find out the most important ones are the ones that don't have a good experience and how we can improve that. I was saying earlier about the additional observations. This is the prescribing process. All the drugs that we use now are prescribed electronically, and this is the drop-down box that alerts the person who's looking after the epidural to check the epidural on a 4-hourly basis. Now, this has to be filled in. Once it pops up, it's got to be filled in. If it's not filled in, it doesn't go away, so it has to be filled in. Now, you might say, well, it's just another tick box, but it's actually done while we're looking at the patient. I've done that, so I'm going the wrong way, sorry. This is the other part as well about looking at when we take the epidural out. At the end of the process, we want to make sure we give the patient some information. The discharge information is given when the epidural comes out, and it gives the patient really some information about what to do if they do get any problems at home, because sometimes when they do go home, they might get some problems. It's very rare, but they might get a sudden onset of back pain that's started. They might be getting some pain somewhere else, some loss of sensation. So this gives them the information of what to do, and they can contact us. And it's important that they're able to or know that they can do that. And we will bring them back into clinic and look at what the problems are. So, epidural management from point of insertion to removal. I hope that when you saw this presentation title, you didn't think we were being smug, that we always get it right. Because we don't always get it right. Not always. We do have some adverse events. And we've had some local, some quite recently, local infusion line being attached to a peripheral line. These should be never events, but we know they do happen. Bag of epidural solution being put in a PCA bag. So I want to just quickly look at the bottom one and what went wrong with that. They're two completely different pumps in the respect that we've got a pump for a case for the epidural and we've got a bag for the PCA. Now we use 500 ml bags for the epidural and we use 100 ml bags for the PCA. Now I don't know if anybody's tried to get a 500 ml bag in a PCA bag, but you'd have to give some going because there's not a lot of space, so you'd have to really squeeze it in. So we need to look at what went wrong really. There was a number of things. We had 2 prescriptions on the electronic process on the system. We still had the epidural prescribed, despite the epidural not being in situ. We had a patient-controlled analgesia prescribed as well. The epidural had not been discontinued after it had been taken out, and that was one of the problems. But it came down to human error, really. The staff that was looking after it, 2 people checked the controlled drug out of the system, but yet they chose the epidural. So you have to look at how did that process fail. So we are looking at changing the checking of the CD drugs. So it's really about when you're, there's always going to be some human error. It's about looking at the problems that occur. It's about looking at the adverse incidents and trying to minimise that risk. You're never going to get rid of human error completely. So we're doing some work around that. So epidural management from point of insertion to removal, getting it right. Not always, but the immediate challenge to improving the quality of surgical care is not discovering new knowledge, but rather how to integrate what we already know in practice. And I put this in for Alison because it's her favourite quote. Progress in patient safety were made not only by doing new things, but doing better the things we already do. So I know it was a kind of a quick resume about epidural management. I hope it's been useful for you. Feel free to contact us at any time. We're more than happy to share things with other hospitals, and I hope you enjoyed the presentation. Thank you very much. Any questions? Now, if I don't know the answer, I've got my colleagues here that will certainly.
Just take a couple of questions.
I didn't do too badly with time there, did we? No.
I'm sorry for you having to repeat what you said, but just to clarify.
Yeah.
You said that all patients who have epidurals go to an HGU area.
Yeah.
Does that mean
Thoracic epidurals.
Okay.
Yeah.
And the primary treatment for hypotension is noradrenaline?
We use noradrenaline, yeah.
So do all them patients have central lines as well as epidurals?
Not all.
Yeah, so most patients who have a thoracic epidural, because if you, I guess the argument is, if your surgery is so significant, or your comorbidity is so significant that you require a thoracic epidural, then you probably use a central line as well. I know some places don't. I know some places use ephedrine and some places use metaraminol peripherally, but we tend to put a central line in everyone, and we tend to write them up for noradrenaline. And part of what we were discussing before about forcing features is when you prescribe an epidural through the system, you also end up prescribing noradrenaline unless you go and click it, so it's already prescribed. We used to use dopamine so that you could give it peripherally. We used to use dopamine. The surgeons started moaning and complaining and saying that they liked noradrenaline because other places use noradrenaline. And there may be advantages to noradrenaline in that it causes more squeeze without so much cardiac effect. But the idea is that it should be about a bit of squeeze really. So that's why we use noradrenaline rather than anything else. And we try to encourage people by having the noradrenaline written up not to drown their patients beforehand, which will be a subject that Rachel may touch on too.
Is there any benefit of fixing the catheter, tunneling it, through tunneling rather than putting a...
So there is a question. The question is there an advantage to tunnelling?
Yeah.
And what I would say to that is that as a consultant anaesthetist, some of my colleagues will tell you there is an advantage, and some of my colleagues will tell you there's no advantage. I sit in the second group, but most of our intensivists tend to tunnel them. And most of us who aren't intensivists don't tend to bother. I don't think there's some good evidence base.
Well, I suppose our fallout rate was 15%.
Yes.
And I think since we've been using the locket, we've seen that come down quite significantly. And I think from a nursing perspective, we prefer a locket device. I think once you've got tunnelling, they've done this other thing with tunnelling as well, which I don't know if it's unique to some of our intensivists or not, where they leave a bubble of the epidural catheter at the actual entry site and then tunnel, and so you've got two bits of catheter, and I think that causes some confusion when we're taking them out as well. So we prefer non-tunnel, and we prefer the locket device, though we recognise it's got some drawbacks.
Thank you.
I prefer not the locket device.
That's so
System.
Can I ask, do you check your INR on every patient?
No, we don't. We did get into a situation where it was being checked, wasn't it? And we don't know how that happened, but we don't check it on a routine basis unless we've got some concerns regarding, or we know that the patients have been on, treatment anticoagulants previously. So we would do that. If we've got any concerns, we always get one of our pain consultants to consider it as well.
Okay.
revert to after if an epidural comes out?
Well, we use morphine, but we have a policy where that if a patient's over the age of 70 or is allergic to morphine or has renal impairment, we'd use oxycodone. Yeah. But again, it depends on, sometimes the anaesthetist or the doctors have a preference. They like a particular drug more than the other. But generally it's morphine unless they've got those other indications.
For some of the bigger cases, some of these operjectomies, we often step down to PCA first of all and then go on to oral. And similarly for our over 70s, we use fentanyl in our PCAs. So for over 70s and renal impairment, it will be fentanyl.
Okay, I think if there are any more questions, we're happy to answer those over lunch, but it is time for lunch, so an hour.